for any prospective physician. In other words, cirrhosis is very important to be understood from any other specialty, and especially the internist, and especially the gastroenterologist and hepatologist. Because cirrhotic patient is going to go and have to be evaluated for emergent surgery. Let's say that they have bone fracture, then the orthopedist is going to call us and say, hey, can you evaluate this patient, see the assessment prior to the surgery. Cirrhotic patient can develop acute kidney injury. They can develop any other disorders in addition, and like any other patient, they need care with comprehensive and multidisciplinary approach. All right, let's start with the first question, okay? This way that we're going to try different approach, right? We're going to start with a question that might lead into the topic. So Mr. Jones is a 56-year-old gentleman who was presented to the ER with 3 days history of confusion, jaundice, and abdominal distension. He have lost his appetite, but nonetheless gained weight. He have no fever or abdominal pain. He mentioned to you that he was diagnosed with hepatitis C virus from drug use many years ago and never got treatment. On exam, temperature 37.6, heart rate 67, respiratory rate is 80. He is disoriented to time, place, but could tell his name. His skin and sclera are jaundiced. His chest was showing his spider angiomas. His abdomen, as shown in the picture, based on his history and physical exam, you concluded that the liver is the etiology of his presentation. At this point, what would be the best description of his liver disease? Let us try something new here. I'm trying to see the pool. All right. Go ahead, answer. You have what? Is it easy for you to see the pool?
Yeah.
Abdullah, تقدرون تشوفون البول؟ Okay, go ahead and answer that. يلا يا شباب, 28 people did not respond. How so? Only 14 people are alive. 16 people are alive, 28 are dead. You see the responses as well, Abdullah Reem?
ايه بس خلاص دكتور ما نقدر نسوي ريسبونس الحين
دكتور.
انك طلعت في الوجه.
You cannot make response anymore?
ايه لا خلاص لانك طلعت النتيجه.
Okay. I see. Hide response. Okay. خلاص طيب. 28 alive again. Okay, we are happy. Oh, nice. كلكم شفتوا اللي جاوبوا هنا وبديت تغشوا منهم. طيب. ما يخالف نمشيها لكم. So majority got it right, which is D. Okay. Let's see this side response. All right. So yes, it is decompensated liver cirrhosis, and the reason behind that is you are already looking at a distended abdomen, which is acidic fluid. All right. So what is cirrhosis? It's a pathological process characterized by fibrosis and conversion of a normal liver architecture to structurally abnormal nodules known as regenerative nodules. And the regenerative nodules, once they develop, then, then you can name it as a cirrhosis. It is the final stage of any chronic liver disease by a variety of causes. In general, it is considered to be irreversible in its advanced stages. All right. So once you have cirrhosis, that's it. You have cirrhosis. It is the ninth leading cause of death in the United States and 14th worldwide. Most patients died in their 50s to their 60s. Okay. Here, this is the appearance of normal liver, and this is the appearance of cirrhotic liver. And by the way, this is enlarged liver. It's shrunken, it's stiff, and it's nodular. All right, nodular. Now let's look at the histological view of the liver. And if you see here, the hepatocyte is the functional is the liver cell that then constitute the functional unit, which is the lobules. And the lobules are hexagonal in shape, and they are covered in the center by the vein that is draining from the hepatocyte, and in the periphery you have the triad, which is composed of um, the branch of hepatic artery, all right, and you have which have the blood supply or the oxygenation, and you have the branch of the portal vein, which have the nutrients that came from the gut, all right, and those are flowing into the hepatocyte, and then you have the duct that collected from the canaliculi um, that came from the hepatocyte. So the direction of the bile duct is actually outgoing from the hepatocyte into the portal triad, and therefore going into the biliary system, into the CBD, and therefore into the duodenum, all right, through the sphincter of Oddi. And the uh, um, therefore, once we understand how is the constitution of liver, we understand the tremendous blood and nutrient supply and the important job of the liver, which is the first organ to receive the nutrient incoming from the gut to detoxify and redistribute the lipid, protein, um, and the carbohydrates into their either complex form or simple form. Okay, so guess where's the what is it called? The gluconeogenesis, the glycolysis, and all the beloved biochemistry is happening here, right? Okay, so let's see. Again, another closer look at the normal liver and cirrhotic liver, shrunken, stiff, and nodular in appearance. When you look at the liver histology, this is the the triad, the spaces here. This is the vein, the artery, and then the nutrient, the bile duct, and these are going into the center. All right, going into the center of the vein and the artery. The vein coming from the portal vein, the artery is the hepatic artery, and supplying the entire lobule, and then going into the central vein, where it's going to the hepatic vein and vena cava and the right side of the heart. Okay, and this is every functional lobule, the functional unit of the liver. Now, in the cirrhosis, you have the regenerative nodules, um, where you can appreciate the fibrotic bands forming these nodule, therefore perfect definition of a cirrhosis, and you can appreciate the disturbance of the normal blood supply and biliary um, um, system being also disturbed. Now, there are common causes of the cirrhosis, which we all know about the chronic viral hepatitis, alcoholic liver disease, non-alcoholic fatty liver disease, which is, by the way, now it's becoming the first cause of liver cirrhosis. And, before that, we were dealing with the hepatitis B and C viruses, but we reached to a curative management of hepatitis C. We already have a controlling medication for hepatitis B, meaning that we can get it under control. But with non-alcoholic fatty liver disease rising up very, very in a very scary approach, given the diabetes incidence has been increased, the obesity and hyperlipidemia, which is a triad for metabolic syndrome leading to the what we call as NAFLD, right? Hemochromatosis also is common, not here necessarily, but in the European and American countries, they have it there very commonly. Other metabolic disorders like Wilson, alpha, antitrypsin deficiency, or it could be cholestatic and autoimmune liver disease, biliary obstruction, and therefore, when we don't know the etiology for liver cirrhosis, then we call it cryptogenic, okay? In the old days, cryptogenic mostly was explained by NAFLD, but however, is just, when a non-alcoholic fatty liver disease becomes cirrhotic, then it's hard to to know the etiology for sure. Okay, moving on. So when we speak about liver cirrhosis, we have either it is compensated cirrhosis or decompensated cirrhosis. So in compensated cirrhosis, the diagnostic workup showing consistent findings of cirrhosis. However, the synthetic liver function is preserved and there is no cirrhosis complication. When we talk about the decompensated cirrhosis, it does mean that you will find a diagnostic workup consistent with cirrhosis, but you will find also reduced synthetic liver function. Remember, we talked about the INR, we talked about the total bilirubin, the INR and albumin, but this is not the definition of decompensated cirrhosis, defined by three things. When you have ascites, you call it decompensated cirrhosis. When you have hepatic encephalopathy, you call it decompensated cirrhosis. When you have esophageal or gastric or rectal varices and it's bled, so variceal bleeding, you can call it decompensated cirrhosis. Those are the three things that can define the decompensated cirrhosis. Okay? So when you say it's decompensated cirrhosis, us as a hepatologist, we understand that you mean the patient have ascites, hepatic encephalopathy, and or variceal bleeding. One of those items will define the decompensation.
دكتور
Yes.
دكتور الفاريسيل بليدنج يعني لازم بليدنج ولا لو فاريسيلا بس دايجنوست يعني كسكرينينج يعتبر ديكومبنسيتد؟
Have to bleed. Have to bleed.
Okay.
Have to bleed. If it didn't bleed, you don't call it decompensated. Okay.
Okay.
All right. Excellent question. Portal hypertension. So the pathogenesis, if you want to understand, it's a complex process, but if you want to think about it, there is a increase in the blood volume. There is a splanchnic vasodilation at the portal circulation, and there is increased cardiac output that led to increased splanchnic blood flow, and therefore increase the portal venous blood flow. And that will increase the portal pressure, and you have therefore increased in the portal circulation, leading into what we call as portal hypertension. But look at it, it's a physics, okay? So it's a blood flow and resistance change, then that will increase the pressure, right? It's resistant and flow. So the resistant, because the portal splanchnic portal intrahepatic and extrahepatic is just increased. The vasculature resistance have increased, and you have increased blood flow that will lead into the cirrhosis. And if you want to know why this is happening, then this is why. Remember, I told you, if you look at the cirrhotic liver, you see a shrunken, stiff liver. So, of course, if the blood coming from the gut, the blood coming from here into the portal vein, and then supposed to go to the liver, but finding it is resistant in the liver. So the and guess what's going to happen next, which is increase in the pressure backing up into the gut and everything else, which is the portal circulation, which is leading to ascites and varices in the vein. Okay, and can lead into portal hypertensive gastropathy, all the other symptoms. Also backing up to the renal failure because of the renal vasoconstriction, which thought to be happening from two etiologies, backing up of the blood flow and the the chemical that lead into the pre-glomerular dilation. All right. So, with understanding of the portal hypertension, you can understand why the patient will end up having jaundice, the smell of the patient as a fetor hepaticus, which is acetone, smell very distinctive, the spider angioma because of the hormonal changes of the cirrhotic patient, because of the lack of the protein bound that is supposed to be synthesized by liver to decrease the hormones. So the hormones are more free than the spider angiomas. The gynecomastia will arise. The jaundice, we understand why, because of the disturbance of the biliary system. And the portal hypertension will lead into splenomegaly and therefore thrombocytopenia. Also, the patient will have hepatic encephalopathy because of the portal hypertension. The varices, ascites, testicular atrophy, amenorrhea, decreased libido, loss of pubic hair, all because of pulmonary edema, because of the hormones. Then you have the volume overload and lower extremity edema by pressure, and then the muscle mass loss because of the protein loss, decrease of the synthesis. Closer look at the varices. This is the esophageal varices. This is second column, very large, and this is third column. And then you can see this here, the red dot, and this is another red dot. That's what we call red whale sign. And this is what we consider as an alarming symptoms, and we have to place band here. Okay, we band it. We do endoscopic variceal ligation. Okay, to prevent bleeding. If we leave this, it's going to open up and bleed. This is the same. This is a spider angiomatous. You can appreciate the palmar erythema here and the caput medosa. Now, if you remember, I spoke about that the INR and the synthetic function have a role in the prognostication. Assessment, meaning the assessment of the liver function. And this is where we assess the liver and the cirrhotic patient. So we have two systems. The older one is the child Turcotte-Pugh score. Excuse me. This depends on the total protein, total bilirubin, albumin, INR, ascites, and hepatic encephalopathy. Those will constitute the score, and based on the score, you will classify into A, B, and C based on the point. And you will have 1 or 2 years survival. Let's look at this. Let me explain to you. If you have a patient with cirrhosis and have no ascites, and no history of hepatic encephalopathy, and albumin is normal, and total bilirubin is within normal range, is class A, and his 2-year survival is 85%. If the patient have hepatic encephalopathy and large ascites, and INR is 2.2, and albumin is decreased to 8, let's say, okay, and total bilirubin is 5, then this is class C. So the class C, the mortality rate is increased because he only have 35% survival in 2 years. Okay, see the huge drop between class A to class C with the mortality in 2 years. Okay, and then we have the MELD score, which is the Model of End-Stage Liver Disease score. And this was developed to assist the patient in a closer look for the liver transplant purpose. We have a lot of cirrhotic patient awaiting for liver transplantation. And in order to navigate who needs and who doesn't need, or they all need, but who needs the most, let me say that. From class C, I'm not talking about A, we're not going to look at that either, or B, it's just class C. You're going to look into a scoring system that very oriented to his labs to see whether the patient creatinine is okay and is he having dialysis. We added sodium to the multi score, and nowadays there's more than ratio because it takes in consideration 3 months mortality, not 2 years survival. We want to make sure that the priority goes to the people who need it the most. Because if the score is 40 or more, then over the next 3 months, they have mortality of 71%, which is huge. And just to let you know, when do we send the patient for transplantation evaluation? Is that when the MELD score is 15. When the MELD score is 15, we send the patient to a liver transplant center to get transplantation. All right, so this is the utility of the prognostic score system. But also, not only that, even if the patient, let's say that, yes.
دكتور كيف البوينت أعدهن؟ يعني بناء على إيش؟ 5 إلى 6 مثلا بوينت، شلون أحسبهن ذول؟
You don't need to worry about that. This is really there is a lot of application that help you. I'm not going to ask you to calculate this point. You're not required. We are not required to calculate it. Okay, I use calculator in my fellowship. All right, but there is a calculation method for that, and based on the scoring system, you're gonna determine. So it's not as simple. Child Turcotte-Pugh, you can calculate the points, but this one you cannot. So I'm not really expecting you to calculate this. There is an app for that. All right. Okay.
تمام دكتور.
دكتور سؤال.
As I was saying, the prognostic scoring system, not only for the transplant evaluation, but also for the evaluation for the palliative care approach. If the patient, let's say that the patient is having hepatocellular carcinoma, he has cirrhosis, he has hepatocellular carcinoma, heart failure, he is 80-year-old gentleman who also have chronic kidney disease. Even if I sent him for liver transplant evaluation, he is not going to be granted one for sure because of high mortality for him. Liver transplant is a very, very tough surgery and need proper evaluation. In other words, patient have to have a perfect heart, perfect other organ to handle the transplant, or to have, let's say, if he to have a liver and heart transplantation or liver and kidney transplantation. It's been done. But if they can't, then we know what's the mortality for this patient to determine what we should do for the patient in terms of palliative approach as well. Okay. Someone had a question?
دكتور
Yeah.
بالنسبة للكريتيريا حقت التشايلد سكور الاي ان ار هي نفس الكريتيريا لو حطينا مثلا بروثرومبين تايم بدل الاي ان ار نفس الخانة صح؟
لا. No.
مختلف.
You put the INR. INR is different than PT because the PT. So what's the INR? Do you know what's the INR? Who can explain the INR for me? International Normalization Ratio.
It's based on the BT, prothrombin time.
Yes. And what based on that, but what also does depend on? Based on PT and what? Does it have another value? يا شباب. I mean, is it based on something else, the community?
Could it depend on the average prothrombin time in the community? So normalized.
Right, in the community. So we depend on the average for people, right? So we depend on average for people for normalization and it's ratio. So you cannot put PT. PT is the normal limit up to 12, and then the INR is 1.2, or it could be 2, or it could be 3 at most. So it's just what I'm trying to say is the value is different. So you cannot put PT value instead of INR. Right? They are very fixed, straightforward, fixed calculation method. All right.
شكرا جزيلا دكتور.
So the diagnosis of cirrhosis. الله يحييك. So you start with doing and as we spoke about the AST and ALT ratio, and the suggestive ratio, as we said in the lecture, is AST more than the ALT, more suggestive of cirrhotic patient. And then you check the total bilirubin, the direct and indirect albumin. I'm sorry for the misspelling here, GGT, blood count. But very important also, you work up the etiology, okay? Find what is the etiology for liver cirrhosis. Why is that? Because even though the patient develops cirrhosis, if it is hepatitis C, unless we treat the hepatitis, continue to have inflammation until it becomes decompensated and increase the mortality. In other words, I need to stop the process of liver, what we're trying to do. So always, always, always that we work up and find out why the patient have liver cirrhosis. Of course, you start with viral hepatitis serology, iron study to rule out hemochromatosis, and then you put in the autoimmune markers, the smooth muscle antibody, anti-nuclear antibodies, and then the IgG, those three markers for the autoimmune hepatitis, then AMA, as we said, for PBC, the IgM also for the PBC, for the primary sclerosing cholangitis, cerebroblasmin, and the copper, 24-hour urine copper is for the Wilson. And then you check the lipid profile, hemoglobin A1C for the fatty liver disease, okay? Then, you go for the next step, which is the ultrasound. So what would you do? Right upper quadrant ultrasound or complete ultrasound? In other words, would you be limited to the liver and gallbladder ultrasound, or would you do complete abdominal ultrasound? And why?
Complete is better because
Sleep. Why?
because we need to see all the abdomen.
Why? Why? Open the mic. I want to see your nose. I want to listen to you. Why complete? Come on, يلا شباب. Why complete يا بنات? Why
Because
complete?
to see all the abdomen, not just the liver.
To check the blood flow as well for the
Why?
for the
What do you
other
want to
part.
see?
Because the
Visualization.
portal
Or
vein is
each.
obstructed.
What are you checking for?
Serology.
So I might
What?
to check the whole abdomen, like if there is obstruction of blood or re retrograde, like duplex
You
Serology.
are close to the answer. So you need to do complete ultrasound because you want to see if there is ascites. Remember, we spoke about portal hypertension, right? So yes, you want to see what you said about portal venous to see if there is ascites, if there is splenomegaly, then we can say this is, portal hypertension, not only cirrhosis, portal hypertension. Does that change my management? Yes, because if I see ascites and I see changes in the liver, shrunken liver, then I don't need liver biopsy to confirm cirrhosis. Most of the time, we don't do liver biopsy, by the way. CT scan and MRI of the abdomen, we only need them for a legitimate use. In other words, if I see a mass by the ultrasound in the liver, then I need further characterization. So I have a legitimate reason to do CT or MRI. Not every case we do CT and MRI. All right, assessment of the liver disease. We might use it when we are not sure if the patient is cirrhotic or not. In other words, if I don't see portal hypertension, I don't find varices in the endoscopy, I don't find ascites, I don't find splenomegaly, other evidence of portal hypertension, then yes, I need to see if the patient's cirrhotic or not. We can do it by serological markers, like the fibrosure, or fibro test or fibrospect. Okay, these are in the blood and can be representative of the fibrosis. Fibrosis, it's stage 1, stage 2, stage 3, and stage 4. Stage 4 is cirrhosis. Okay, so when you do any of these tests, the value, it's going to give you a value, and the value is correspondent to, according to the charts, to one of these five numbers, either correspondent to F0, which is non-cirrhotic or no fibrosis, F1, F2, 3, or F4. And 4 is cirrhotic. F0 to F1 is minimal, very minimal. So most of these tests are very reliable to tell you if it is cirrhotic patient or none. But in the middle, it's really so-and-so. It's not that accurate, all right? We have also imaging tests to estimate that, which is the MR elastography. It's MRI with elastography or transient elastography. And I will explain it a little bit, but it's the similar concept, okay? And then we have the invasive one, which is the liver biopsy. And the liver biopsy can evaluate the etiology as well and give the extent of the inflammation. In other words, grading as well. As you know, there is grade 0, 1, and 2, and 3. The cons of this test is that it is invasive, so there are risk of complication and misrepresentative sample. Maybe you overdiagnose by telling it's F4, and it is not true. You just took from an area that it's more cirrhotic or more damaged, while the average area is F2, for example. Or it could be underdiagnosis. You take it from normal area that really you miss the diagnosis and the staging of the liver disease. The transient elastography is like an ultrasound. This what you see here is the screen of the transient elastography, what we call as fibroscan, and this is a probe like an ultrasound probe. The probe here is different than the regular ultrasound because it have a piece here that will send a pressure vibration, and this vibration send a signal and then come back. Every time you click in this, you get a result, okay? And the result is based on kilopascal, and the kilopascal, let's say it's 9, it's 10, and you take 10 different readings, and then the program, the machine is programmed to give you the average score and the median score. And also this device can tell you how much fat there is in the liver. However, it does have some limitation. The biggest limitation is that you cannot do it on a BMI more than 35. But I mean, if a BMI more than 35, then you can understand that the most likely etiology is non-alcoholic fatty liver disease. So tips for evaluation of cirrhosis: you have to take the social history, especially if the patient is drinking alcohol. Yes.
ذكرنا دكتور many investigation. What are the most important investigation to us يعني?
Look, what are you talking about in terms of diagnosis of cirrhosis or the etiology of cirrhosis? So it's a lot of work, and yes, it is. When I have there is no more important one, because here is the thing: if you come to my clinic, Bismillah عليك يعني, and you are concerned about cirrhosis, then there is a lot of workup to do. The liver clinic have a lot of workup. My liver patient take a lot of time to be evaluated. Okay, so yes, it's extensive for a reason, because this is important, and we established for a long term those who are diagnosed with cirrhosis. So I'm sure that there is something in your mind, I mean, in terms of important, in terms of diagnosing the cirrhosis, or what?
For the diagnosis as well. This is important for us, I think.
Well, it depends, really. It's really depend. This is why you spend, there's a designated fellow after finishing the board for the, gastroenterology and hepatology, as well as designated hepatology fellowship. What I'm trying to say is that it takes time to find out which is important. Sometimes I don't need liver biopsy. If you find portal hypertension, you're done. You have an ultrasound that shows you portal hypertension, then you're done. All your job is done, because you find out that the patient is cirrhotic. But this is not accurate. The ultrasound, whoever said the ultrasound is the most initial test, this is not true. I have a patient, let me tell you a story. There's a patient who was scheduled and was referred to my clinic. Okay. So I open up the chart. I usually open up the chart before the patient arrived to my clinic, and I reviewed it. There is no imaging, but I diagnosed the patient with cirrhosis. At least I am thinking about cirrhosis as a diagnosis for the patient, because the AST more than the ALT, and the platelet number is low. And this is very, very concerning for cirrhosis. Okay, we come back to the tips of evaluation of cirrhosis. So I said social history is extremely important. If the patient is alcohol drinker, if the patient is living a sedentary life, metabolic lipidemia, diabetes, all are risk factors. Platelet level and the CBC and spleen size by simple diagnosed with cirrhosis, and your job is done. Liver biopsy or tissue diagnosis not needed all the time. Okay. Prognostication tools is very important, because you want to determine when you want to send the patient to transplant, and to answer the patient appropriately when they ask about their current status. And then it is important to identify decompensated cases to take the appropriate management for etiology workup. So again, alcohol history, macrocytic anemia, AST and ALT ratio, chronic viral hepatitis. For positive viral serology, you do the PCR to confirm. Congestive hepatopathy, you have Wilson disease, and others as well. All right, we go to the fun part. All right, 54-year-old female was scheduled. Let me check that. Hold on a second. Let me put this in a perspective of pool. ما ينفع البول هنا. Okay. I'm so sorry. We cannot put the pool here. All right. Let's come back to our question again. So 54-year-old female was scheduled in your clinic to establish her care after recent hospital discharge for the diagnosis of ascites. Huh?
موجود pool.
She is in from few pool, but take 6 options. There's no 6 options on it. The multiple choice is limited to 5. Cancel. Okay. Okay. Anyway, so she's from Egypt, was not aware of liver disease prior to her presentation. You reviewed the recent discharge paperwork and found out she had abdominal ultrasound that showed coarse liver consistent with cirrhosis and splenomegaly, as well as large volume ascites. Paracentesis showed PMN 87, SAG 1.3, total protein is 1.1. She is currently in diuretic for her ascites and her distension is much better. She denied history of alcohol abuse. What is the best next step in her management? Okay, give me answer.
Check for hepatitis B
D.
and C.
Someone say D. Okay. D. Nice. Excellent. Yes, true. D. D is the correct answer because we don't need abdomen. There is no reason for CT scan or MRI. The ultrasound was enough. There is no suspicion of a mass. We don't need liver biopsy. We already know that she have portal hypertension. So, and the SAG is consistent with cirrhotic radiology. She doesn't need therapeutic paracentesis because we told you from the scenario that her ascites and distension is much better, and we don't need to repeat her abdominal ultrasound. It was very recent. Now we come to the management. All right. Cirrhosis care. So, like I was saying, transplant candidacy always part of our cirrhosis care. Our patient come to our clinic. I mean, the cirrhotic patient comes to our clinic every 6 months for these items. We do the candidacy evaluation. We screen for esophageal, gastroesophageal varices. We screen for hepatocellular carcinoma. We put them in a diet, low sodium diet when needed, especially as a decompensated liver cirrhosis with ascites. We make sure if they are not vaccinated for hepatitis A and B, we do vaccine for hepatitis A and B, very important. Another infection, okay, let's say that they have hep C or they have NAFLD and they developed hepatitis A or developed hepatitis B, their mortality is high, much high, and you can prevent it by simple vaccination. You avoid hepatotoxic agent, so you have to go through all the medication of the patient. For example, the most important example that you avoid NSAIDs. You're not supposed to give the patient NSAIDs, okay? Cirrhosis is contraindication for NSAIDs for 2 reasons. Number 1, they are prone to bleeding. Number 2, NSAID in the cirrhotic patient can also induce hepatorenal syndrome. Their kidney can fail because of the as you know, the NSAID, I think, pre-glomerular vessel and the afferent vessel. I believe it's in the afferent, or is it in the efferent? I'm not sure. And it will, the efferent, and it will cause dilation. And if it does cause dilation, then it causes renal failure. and rather you give them acetaminophen. Actually, you give them acetaminophen, but limited to 2 grams at most. Maximum is 2 grams. We counsel them. Okay. So many doctors prescribe NSAIDs for cirrhotic patients, which is sad. Nutritional support. Are we supposed to give high protein diet or no? Yes, yes, we are supposed to give high protein. All right. In the old days, there was concern about high protein diet because in hepatic encephalopathy, as we all know, hepatic encephalopathy because of increased protein breakdown, and part of it is the ammonia that caused the confusion to the patient. But this wasn't the issue as being perceived. The protein actually is very helpful, and if we limit the protein intake, the patient become wasted. I mean, their muscle wasted, and the mortality will increase. So you better increase the protein in their diet, as well as the calorie, by the way. Increase high protein and high calorie. Esophageal and gastric varices. So this is, a look at how the esophageal varices looks like. I show you a picture of the endoscopy, the real endoscopy with esophageal varices. You can see this is GOV1, gastroesophageal varices type 1, whereas the varices continuous from the esophagus into the stomach along the lesser curvature. And if it bleeds 70% of the time, and you can band here as well as here. You can band esophageal varices, but if it is GOV2, which is going to the stomach along the greater curvature, you cannot band it. Isolated gastric varices, which is about 7%, type 1, type 2, and we also have type 3. They are non-bandable. You don't band them. You don't band GOV2. You rather treat them with a different approach. Okay, you treat them with a different approach. Now, I'm sure Dr. Umar gave you a lecture about GI bleeding. Similarly here, the approach is almost similar with some addition. So in the initial management of the bleeding, you have to have IV access, IV fluid. You give octreotide in addition, and octreotide is going to lower the portal pressure and therefore lower the bleeding. Also PPI. So in addition to all the management of the GI bleeding for other population, you add octreotide, and your goal of the hemoglobin is more than 7, but do not overcorrect with overtransfusion, because this can increase. If you give more blood than necessary, you can lead into increasing the portal pressure, and the bleeding will get worse. With the bleeders, the various bleeders, you have to make sure that the platelets more than 50,000 and the INR less than 1.5. Esophageal varices are small and large, and you can do banding, and you give non-selective beta blocker for the non-responder. You put tips eventually if it doesn't, get controlled for life-saving method. Gastric varices, the treatment is with band ligation only for GOV1, as I said. You have the choice of glue injection, meaning that you inject glue in the varices, but the problem with that have about 7 to 10% of pulmonary embolism, and that is why you do radiology. Ask the interventional radiology to do BA2 TO, the balloon occluded retrograde transvenous obliteration, BRTO, or BAT. And unfortunately, this have to have approach. Not all the patient can have this done for them. It depends the anatomy. It depends on the anatomy. So usually the interventional radiologist will ask angiogram and then see if he can approach the varices or not. All right. This is esophageal varices with no high risk. I mean, this is large, of course, because you can see it's large esophageal varices, but no red whale sign. This is how does it look? Bleeds very scary in the esophageal varices. This is how it looks. Okay, and this is after we put band. This is band after it's fall off, but this is the how it looks after we put a band. The varices here and image here, you can see this is the bleeding gastric varices. We are looking at this area. Okay, we're looking here in the fundus. So this is a scope coming from the esophagus. And after the injection with the glue, it become hard and looks like that. The systemic shunt, known as TIPS, is the approach by interventional radiologists that they approach through the inferior vena cava, through the transjugular vein into inferior vena cava. Main, usually it's a right. They go into the pleural vein and they create a stent that is a shunting the portal system and the systemic circulation. It is only reserved for the bleeders who cannot be managed otherwise. In other words, there is a failure of hemostasis by other endoscopic and non-endoscopic approach, and for patients who have refractory ascites failed to be normalized or controlled by maximum medication and paracentesis. And have 30% of risk of developing hepatic encephalopathy. However, having that said, you cannot do this with a patient who have, because if you have a patient with right side heart failure and you do a TIPS, guess what you did? If there is increased pressure, all right, in the right side, you made matters worse. And that's what you do, okay? All right, moving on. This is the BRTO. Through the interventional radiologist, they have to have renal shunt, what they call splenorenal shunt in the venous system. They have to have a shunt between the splenic vein and renal vein to approach through it into the gastric varix, and in the gastric varix they put a balloon proximally and distally, and they inject the glue material, and that harden without the risk of embolization into the lungs. This is a real case back in my in one of the liver centers that I work in. You can see here, just I'll show you, see the injection of a glue material through a BRTO approach by the interventional radiology. This is their catheter, and the varix is here. You're gonna see it lighting up in a little bit. Usually with a presentation, Will appreciate it more. Yes, this is with the here. This is the balloon. And this is the obliteration with the glue injection. You can appreciate the glue all over. Again, this is the balloon, proximally and distally, and the glue injection. 57-year-old male with a known history of hepatitis to the hospital with 4 days history of weakness and lightheadedness. He stated that he noticed dark terry stool for the similar duration. Vital signs: the temperature 37, heart rate is 126, which is elevated. Tachycardia, blood pressure is 95 over 78. This is reasonable, by the way, for cirrhotic patient. Respiratory rate is 18. Oxygen saturation is 98 in room air. CBC, WBC is 12,000. Hemoglobin 5.5. Hematocrit is 19. Plus 60 INR is 1.4. What is the best next step for this patient? A, do upper endoscopy and control his bleeding. B, start octreotide and control. C, establish large or IV access and start IV fluid and blood transfusion. D, stool guaiac test. Hold on a second, don't answer. Hold on. We want to do this. Oh my God. All right, that choice. All right, let's go ahead and start. So far I got 20. يلا يا شباب، يلا يا بنات. Show responses. Majority of you said 3, which is C, establish large for IV perform upper GI. Dr. Umar will be pissed at you guys. Those 6 people, Dr. Umar better not see your answer. Okay, hide the correct answer is C. Establish large bore. Still, we are at the basics. If you have a bleeder, the first thing is first. Large bore IV access, that IV fluid and blood transfusion. It will take a lot of time to establish the endoscopy, okay? At least 4 hours. And I cannot do endoscopy before stabilizing the patient. First, we have to stabilize the patient. Okay, my next question. Okay, now choose the next step. What is the next step? C, خلصنا, we done it. What is the next correct answer? Can you choose in the pool? Can you change it? ولا you can't?
ايه نقدر دكتور.
يلا, choose. Which is next? So far, I'm getting the vibe of B. Start octreotide and pantoprazole. Correct. What about? Okay. Let me clear the answers now. What about now after B? What would you do next? So we did C and then B, and then now we do A. Excellent. Okay, we do A. All right. Is there any utility for this? Absolutely not. It gets under my nerves. Okay, let me tell you what I don't like to hear when I am on call. I don't like a resident who call me in the middle of the night. He tell me the same scenario here. Melena, and the hemoglobin is 5.5, and he is so proud about the Gawayak test, the stool fecal occult blood. Like, it's just, you're telling me the patient is bleeding. This have no utility here, okay? You only do that when you are not sure, okay? And majority of cirrhotic patients, they will always have positive Gawayak test, by the way, all right? Because they have portal hypertension, gastropathy, and they are oozing continuously. All right. So ascites. Ascites or large volume. It can cause back pain, abdominal pain, distension, shortness of breath. Really, when they have like 10, 12, 15 liters inside there, for those patients, and that is why when they have such a symptomatic patient, we do right away a therapeutic synthesis, paracentesis.
دكتور
So the workup, you do abdominal ultrasound,
انقطع صوتك ترى تو.
synthesis with that, as we said, albumin, total protein, cell count with differential, huh?
انقطع صوتك انقطع صوتك تو يا دكتور.
اي تسمعون بالاسايتس الحين؟ طيب خلاص خلينا نعيد شوي. As I said, the ascites small or large, and with the large ascites can be very, very disturbed to the patient, and symptoms have to be managed with therapeutic paracentesis. Okay, the approach is what we discussed in the SAG approach before, and the treatment, you start with medication unless the patient is symptomatic with abdominal pain, distension, shortness of breath. If they can handle it, you do Lasix and spironolactone. Lasix is furosemide. We start with 40 of Lasix, spironolactone 50, and then I increase 80 here, and here is 100. We reach up to 160 in the Lasix and 200 in the spironolactone. The therapeutic paracentesis for symptomatic patients, the tips topic, we do the tips for refractory ascites. Always when you do therapeutic, or almost always, you include the diagnostic to make sure there is no is defined by PMN more than 250, and the antibiotic you give ceftriaxone or ciprofloxacin. And then once you treat them for spontaneous bacterial peritonitis, you need to give them a prophylactic lifelong antibiotic, usually ciprofloxacin. Hepatic encephalopathy. It is a brain dysfunction caused by liver or portosystemic circulation. It is manifest by wide spectrum neurological and psychiatric abnormalities, ranging from mental alteration to a comatose patient in the ICU. Diagnosed based on history and physical exam only. Okay, I repeat again, hepatic encephalopathy dependent on history and physical exam only. This could be precipitated by infection, diuretic overuse, constipation, and other causes. You always have to find out what is the etiology behind the hepatic encephalopathy. In other words, it's not only enough to treat a patient with hepatic encephalopathy, give them lactulose. You have to know if there is an infection, you treat the infection. If there is a bleeding, you stop the bleeding. So it could be something that pushes that cirrhotic patient to come with confusion, and you have to find out that when a patient with cirrhosis, they call me in the middle of the night It's like a knee-jerk reflex to me to do chest X-ray, urinalysis, urine culture, blood culture, percentesis if there is ascites. This is my approach. Cirrhotic patient with hepatic encephalopathy to treat the etiology. All right, we had a patient on the floor have been admitted with confusion for a week duration. All right, and he's been treated with lactulose and he does not respond. And then I came for a consultation. I do a rectal exam, bleeding for an entire week with nobody finding out. Does ammonia level in the blood matters? The answer, no, it does not matter to me. Okay, the only benefit of ammonia and the confusion is that if it is normal, if the ammonia is not increased, I can tell you it's not hepatic encephalopathy. Okay, it's exclusion, but it does not help me in the diagnosis of. And this is really, really agitating to the gastroenterologist worldwide. Even in the US, they call me in the middle of the night. Doctor, we have a patient who's been having confusion. The ammonia we have in his mind or her mind, this is hepatic encephalopathy. No, it's not. And then I asked them, does the patient have flapping tremor? They said, we didn't do a physical exam. It's bad. I'll tell you, okay? We divide the hepatic encephalopathy according to West Haven criteria into 4 grades, okay? And you can see it in the in this schedule. From symptoms to a coma. All right. Now, like I said, precipitating factor, hepatic encephalopathy, the overt hepatic encephalopathy. That, you know, one time they came as an acute, you have to think about infection and GI bleeding, those as a number 1 and 2. The same factor is here, but if it is recurrent, then it might be because of electrolyte disturbance, meaning that think about the diuretic that the patient's taking. Okay, but these are the same. You have to work it up. Okay, you have to make sure the patient have no infection, no bleeding, no constipation. Okay, all right. The treatment for hepatic encephalopathy, you can give lactulose, oral or enema, and you give rifaximin. Till recently, we used not to have rifaximin. Nowadays, it is available as a dose of 200 milligram. You can give them 2 tablets twice a day. All right, it's very expensive. Other medication, not that much really. We depend on those. Those are the 2 mainstay treatment for the hepatic encephalopathy. Hepatorenal syndrome is renal failure in a setting of advanced liver disease. Now, what happens is that there is arterial vasodilation of the splanchnic circulation that increases the vasodilator activity, and that's why they developed decreased perfusion into the kidneys. And hepatorenal or 2, the one is very severe. The creatinine is more than 2.5 or twofold the more than normal in less than 2 weeks. And if they develop type 1 HRS, their mortality is very high. They end up into the ICU. Unless they are transplanted, they're gonna die. Type 2 is less severe, but also comes with a high mortality, okay? It can be precipitated by upper GI bleeding, spontaneous bacterial peritonitis, or volume depletion. HRS is diagnosed by prerenal azotemia, intrusive kidney disease, ATN, contrast-induced nephropathy, all the other things that you learn with Dr. Abdulaziz, other etiology, okay? And then you try to correct the underlying liver dysfunction. If the patient critically ill, then we give norepinephrine and albumin to the patient. If he is on the floor, we give octreotide, midodrine, and albumin, okay? And the patient need transplant eventually. There are other complications to the cirrhosis. Hepatic hydrothorax, meaning that ascites, similar to that, a fluid can go to the hepatic hydrothorax and goes to the pleura, okay, goes to the pleura. The ascites. Question, do we do pleural thoracentesis? No, the answer is no, we don't do pleural thoracentesis unless it's very, very severe. We don't like to do that. Syndrome is microvasculature alteration and dilation and the precapillary and capillary pulmonary artery circulation, leading to decreased oxygenation of the patient. Portopulmonary syndrome, development of the pulmonary hypertension. So in a setting of portal hypertension, all right? So primary pulmonary artery hypertension because of the because of the cirrhosis. And those are really, once the patient develop them, we consider transplant up to a point where the if it is passing that and the patient is, you know, even the transplant is not an option anymore to that patient. All right, we're reaching to the end. Okay, 58-year-old female with a history of hepatitis B infection brought to the emergency department by her husband with a history of abdominal distension and confusion for the last 3 days. She was first diagnosed 30 years ago, thought to be related to IV drug abuse. She is confused and unable to provide further history. On exam, temperature is 38, respiratory rate is 24, heart rate is 110, blood pressure is 82/40. She is cachectic with temporal wasting. She appears on respiratory distress and with abdominal distension. Lab shows WBC 16,000, platelets 60, creatine 1.8, abdominal ultrasound showed severe ascites. So let me see who's here. I'll choose randomly, okay? Sarin. يلا عبد الله, open. Abdullah, open your mic.
Assalamu alaikum. According to the history that we have at the vital signs, he appears to have.
Abdullah, my question. Right. Right. Abdullah, لحظة. My question to you, based on this history, what is your diagnosis? What is the patient's, what kind of complication the patient have? Complications of cirrhosis.
A hepatic.
What am I trying to tell you here in the question? And what else?
Hepatic encephalopathy with an infection. There is an infection, but we don't know what exactly.
So what is your answer to this?
Start empiric antibiotics.
A therapeutic paracentesis, huh?
أنا بختار لا empiric antibiotic.
Empiric antibiotic. Okay. Let me put the pool. Oh, I have A, B, C, D, E. Okay, hold on a second. Hold on a second. Yalla. What is your answer? I want everybody to answer. I have no I will be pissed if nobody, if someone have no response. I'm okay if you have a wrong answer. I'm not okay if you don't answer. 20 people did not answer. Where are you guys? Video game. Stop playing with the game. All right, 15, better. All right. Okay, guys, start answering. 10 people did not determine yet. Go ahead. It's okay. Make mistake now. I want you to make the mistake. I want you to learn today. Exam is a problem. This is not a problem. All right. 9 people did not answer. I think they are somehow away. Okay. 8. Okay, good. All right. We're going to close the poll. Last call. All right. Show response. Okay. So, which is obtained to X-ray, urinalysis, and culture. And some people have answered start empiric antibiotic. 2 have answered CT scan. Oh, someone chose liver biopsy. Oh, why is that? And some have chose therapeutic paracentesis to relieve the symptoms. Well, okay. Let us talk now. Let us talk. We have here a distinction and confusion. So we have confusion, right? So this is a hepatic encephalopathy patient. There is no doubt this is a hepatic encephalopathy case. I'm telling you, she's cirrhotic from hepatitis 30 years ago. And now she is coming with infection, as Abdullah said. So WBC 16,000, she is febrile and with acute kidney injury, okay, with acute kidney injury. So there is something wrong happened to her, right? And we don't know what it is. So when you don't know what's going on, then you start approaching the sepsis, the fever approach, which is first, you have to do this. As I told you before, always when you have hepatic encephalopathy, you do infectious workup. They call it in the hospital infectious workup. Chest X-ray, urinalysis, urine culture, and diagnostic paracentesis. Also blood culture, by the way. Okay? And after you have done that, it is okay then and only then you start with empiric antibiotic. But before you do that, before you start the antibiotics, you have to do your infectious workup. You have to find out where is the problem. Because if you have then you're gonna maintain on antibiotics even after discharge. If you have urine infection, you might choose the antibiotic differently. If it is pneumonia, then a different antibiotics. Okay, and yes, she have abdominal distension, but she have also acute kidney injury. So you're gonna give diuretics. You might want to do paracentesis, but after those 2, I will do limited therapeutic paracentesis. Okay, so you notice that there are 3 correct answers in this scenario. However, it's all about the priority. So priority number 1, infectious workup. Priority number 2, then you start antibiotics. Yes, I want to start antibiotics, but first you have to know the diagnosis. And then number 3 is that the therapeutic paracentesis. After that, we come to the perform liver biopsy. Really, there is no reason to do that. We know she's cirrhotic. She had portal hypertension. So why would I do liver biopsy? There is no indication. We know the etiologist, hepatitis B. So I'm done with her. Unless I have a tumor, I have something to call for liver biopsy, there is no need. CT scan of the abdomen is not indicated right now, and I cannot add contrast because of the acute kidney injury. Yes, Abdulillah, what's your question?
دكتور شلون يعني ما اعطيها انتبيوتكس بروح اسوي اكس راي ويورين اناليسيس ويورين كالتشر تول تيك تايم والمريض يمكن تسوء حالته وانا للحين ما بديت ولا انتبيوتكس وانا ادري ان عنده انفكشن.
How long does it take to do all this?
الصراحه ما ادري بالضبط يعني بس انه يعني انا شايف انفكشن بعطيها امبيريكال انتبيوتكس.
Excellent. Thank you for telling me this. Abdulillah, no, that's not true. So all these things can be done in the ER within 2 hours maximum. They can do all these things. They would be happy. ER would be happy to do that, and blood culture. Because once you start blood culture, okay, blood culture, DC, blood culture, all right, they will be happy in the ER to do that. It's very easy to do that. But what you don't want to do is start antibiotics without knowing the etiology. So why would you start antibiotics? Ask this Dr. Abdullah Jurayed, and he will not be comfortable with your answer. And he is the infectious disease guy. So if you ask Dr. Abdullah and said, okay, do we give antibiotic without doing the proper investigations? He would be angry at you. And so why would you give antibiotics without knowing the etiology? It is a rule in internal medicine that you do the investigation first before that, because this does not take more than 2 hours. It will not take. It should take under 2 hours. I don't want to wait. I did not tell you to wait for the results. I have told you, you collect this. Then, as soon as you collect it, you do the chest X-ray. If you find pneumonia, that is fine. You have your diagnosis. You treat pneumonia, whether it's community-acquired pneumonia, hospital-acquired pneumonia. Difference, just we have a protocol for antibiotics. If you find this UTI, then you can treat UTI. But this 2 hours, and then you can give empiric antibiotic. I have no problem with that. But you have to obtain it first. Clear, Abdullah?
اي واضح دكتور واضح جدا جزاك الله خير.
I am happy that you asked. Yes, because this is the rule, and this is not only the cirrhosis rule, it is medicine rule that because if you start antibiotic, you might miss the chance of diagnosing the bug. Let's say that I have here MRSA, all right, or I have Staph aureus, right? Staph aureus. We understand MRSA, Staph aureus is methicillin resistant. If I start them both with vancomycin, all right, they both are going to respond, right? They're all going to respond. But then 3 days later, you're going to ask your question. The patient is feeling better. I want to vancomycin is IV medication. What should I do? Then we ask you, is it Staph aureus or is MRSA? Or is it vancomycin? Vancomycin resistant VRSA. Huh? So how can you determine without a culture? You can't. You can't. Let me tell you a rule in medicine. You plan discharge of the patient the moment that you admit the patient, meaning that you do the proper workup from the start. To plan for the discharge antibiotic, you have to do the proper workup. Okay? To the end of the lecture.
دكتور
Any question?
دكتور بالنسبة
Guys,
للA اللي هو
أيوة.
ثيرابيوتيك باراسينثيسيس ليش اسويه يعني بالضبط اللي هو شورت سبريت؟ هل هو بسبب الاسايتس او بسبب ايش؟
معليش عفوا انقطع اتصالك. الاي وش فيه؟
اللي هو الفيرست تشويس. why we do it يعني for shortness of
ايه
breath but
ايش المشكله فيه؟
because of the ascites or what's the indication for it يعني.
symptomatic patient, respiratory distress, abdominal distension. I will do limited, by the way, paracentesis because of the acute kidney injury. I will do only 3 liters, 3 to 4 liters maximum, but to relieve the shortness of a breath.
So I do
واضح؟
limited when I have kidney injury. This is what limit me يعني.
Yes, but listen, this is not kidney injury, not kidney injury. This is not as at your level as medical student. أنا ما أتوقع منك إنك تعرف الكلام هذا. أنا بس قاعد أقول لك وش قاعد أفكر فيه. الكلام هذا اللي هو kidney injury, we limit the paracentesis not at your level. Even the resident, we don't, it's just the higher level. What I'm trying to tell you is that the basics is this: when you have hepatic encephalopathy, then you have to work up the etiology. This is the whole purpose of this question. The whole purpose of this question is that the entire that we infectious workup and know what the etiology of this patient hepatic encephalopathy. If I do a rectal exam, then you do rectal exam to find out if the patient is bleeding. Okay. Look, listen, every topic have advancement, and even if you go to other topics like chronic kidney disease, it have a limit for you guys, a medical student. We expect something from you. All right. I don't expect advanced management from you, but I expect the basics. And the basics I explained very well in this lecture. That when you have hepatic encephalopathy, you depend on the symptoms, which are the confusion, which are disorientation, flapping tremor on physical examination, not the ammonia, and you have to see what are the causes for the hepatic encephalopathy. The treatment is lactulose and rifaximin. This is as short as it is. Okay. Same goes for ascites management, definition, workup, and same go for the entire cirrhosis. Okay. Any other questions?
دكتور إذا ممكن متى نستخدم ليش نستخدم اللاكتيلوز في اللي هي hepatic encephalopathy؟
Right. So lactulose is used in the hepatic encephalopathy because we believe the confusions caused by the absorption of the gut protein and microbiota that lead into the confusion of the patient. So we relieve them by inducing the diarrhea that decrease the amount of ammonia production, protein and bacteria and portosystemic circulation, and that improve the patient encephalopathy. واضح? Because in the normal people, when you eat food, you have the nutrient goes through the portal system, then go to the liver and get detoxification. Patients who have cirrhosis, they have portal hypertension and they develop something called cavernous malformation, where the blood supply is mixed. So the portal vein get mixed with the there are portosystemic shunt. And this where the toxin passed from the liver into the system. So we believe that if we induce diarrhea, it's improved. Rifaximin is antibiotic. Okay, we kill the bacteria in the gut that produce the toxin. And rifaximin is non-absorbable antibiotic, stays in the gut. Okay, but it does not induce diarrhea. Lactulose induce the diarrhea. Any other questions?
دكتور
عمر سام.
تسلم. دكتور ممكن تروح الكيس 2 اللي ظاهر لنا سلايد 20.
سام.
تسلم. يا دكتور هنا لو قال لي انه الديستنشن نت امبروف، البيست ستيب راح تكون ايه الجواب؟ هل الكلام صحيح ولا لا اظل تشيك فور هيباتيتس بي ان سي؟
Well, if it is not improved, then both of them are true. لو ما تحسن D و E correct. شوف في الأسئلة زين الآن let's move on to another topic. زين ما هو في cirrhosis. When you have questions in the exam, we are not gonna make it ambiguous. All right, we don't make it ambiguous. Not here in the college, not in the SMLE, not internationally. Okay, we understand. Make it as clear as possible, as well as we channel it toward one diagnosis. So when I look at it, all right, when you look at any question, for me, in the exam, when I sit for the exam, I read this first. What is the best next step in her management? I don't read the choices. I read this because I want to know what they want. I absolutely close this. I close it. I don't read it. And then I read the case. And then, based on the scenario and my own knowledge, I say this is reasonable answer, all right? Reasonable answer. Then I choose it. However, I go and see this. Why it's not true? Why this is not correct? Repeat her abdominal ultrasound. Well, because it doesn't make any sense. In this scenario, she was just discharged. She just had an abdominal ultrasound, and there is no reason to repeat it. She needs therapeutic paracentesis only if I have not said that she is currently in diuretic for her ascites and her distension is not as much better. And even at that time, by the way, I would increase her medication rather than do paracentesis. I look at the liver biopsy. Why would I need a liver biopsy with decompensated cirrhosis? We already have the diagnosis, and we know it is. We have option that is invasive that can tell me the etiology if it is positive. And advanced imaging is not needed in this case. I don't have mass in the liver, or I don't have, let's say, portal venous thrombosis that I need to map out and see and further evaluate. So I have no reason to do. So in any question, when you want to answer, you read the question here, the question itself, and then you read the question stem, all right? And then you decide the answer. And when you decide the answer are not correct. And after that, I reconsolidate, I revalidate my answer. Okay, my answer is still D. I choose it, I move on. And when you choose it this way, don't get back to the question. Don't go back. Because statistics has shown if you do this method and then if you answer your question and then you go back to it again, there is high likelihood that you are changing from right answer to wrong answer, unless you have a legitimate reason. Say that you did not pay attention to this. You have missed this sentence, and now this have changed your answer from E to D. This is a reason, but otherwise, no. Switching the answers after you chose it is the wrong approach. Any other question?
واضح. الله يجزاك خير يا دكتور.
وياك الله يعافيكم. طيب يلا الليدرز يرسلوا لي التحضير. الله يعطيكم العافية. طيب يلا نراكم على خير. مع السلامة.